Good morning, everybody, and welcome to the second session of the 13th Annual Patient Safety Summit. I'm Patty Taylor with the Dallas-Fort Worth Hospital Council Foundation, and I will be your host for today's session. We'd like to thank our platinum sponsor, Methodist Health System, and Texas Health Resources. We'd also like to thank our silver sponsors, Abbott Point of Care, ACHE of North Texas, American Heart Association, Group 1 Background Screening, Health Catalyst, Interactive Quality, Conoco Minolta, and Vital Tech. Thank you to our sponsors. We also really like to thank the Patient Safety Summit Planning Committee. These people volunteered their time to put together the sessions that we are hosting. Without them, you wouldn't have this great lineup of speakers, so thank you to the committee. We accepted 10 posters that can be viewed on our event webpage. Review those posters and complete a short quiz to be entered to win an autographed copy of our keynote speaker, Megan Johnson's Generation Inc. To claim your CEs, you must attend 85% of the session. The evaluation opens after all sessions have been completed, which is October the 2nd. The link for the evaluations is on our webpage. You must complete the evaluation by October 16th, and we will email you your certificate within 1 to 2 weeks after you completed the survey. All presentations and session recordings will be available on our webpage. As a reminder, CEs will only be awarded for live attendance. If you haven't realized yet, everything pertains to our webpage. It's even on the bottom of the slides. Everything that you need to know is there at our webpage. If you have questions for the speakers, since everybody is muted, you can type your questions into the question icon, and time permitting at the end of the session, questions will be answered. We did find a conflict of interest, but it was resolved for this session. And now I would like to introduce you to Audrey Cortez, our first speaker. She's a registered nurse for over 20 years, and much of her time she served in nurse executive roles, including CNO. While Audrey loves leadership and coaching, her main passion is resiliency, and she is here today to introduce us to her model, Steady and Raise. Welcome, Audrey. You should have control of the mouse.
Well, good morning. Good morning, quality people all over Texas. I'm Audrey Cortez, and I'm here to talk to you about our resiliency model called Steady and Raise, and this is with interactive quality. Now, Patty, I'm not able to advance the slides. Okay. So, again, sorry, I'm trying to figure out how to advance the slides here. But I work with interactive quality and I have a day job where I work as a patient experience expert at Peterson Health in Kerrville, Texas. But again, as Patty said, my passion is resiliency. Now, this may not be a surprise to you. I'm going to start off with a little bit of research and background on stress, burnout, and resiliency. But in 2017, Press Ganey identified that the top challenges in healthcare were stress and burnout. Now, note that this is before COVID. Again, stress is inherent in life. Stress can be good. Stress moves us forward. We only grow outside of our comfort zone. We only change when we have to as human beings. So, but stress, everything is stress. You wake up, it's raining. You wake up, you have a flat tire. Your child is sick. You're late for work. All of these are little bricks of stress. But stress over time can build up, and this is what causes burnout. And Patty, it went forward 2 slides. I'm so sorry, guys. I cannot move the slides. So I want to talk a little bit about how burnout really affects quality. When people are stressed out, they do not function at their optimal level. They lose their creativity, and they're not paying attention to details. So again, it is strongly documented in the literature that burnout negatively affects patient safety. So it is a predictor of medical error, and there is definitely a direction between burnout and medical error. And RN burnout is associated with higher infection rates. Also, we lose RNs and physicians at a higher rate when they're burned out. There's a predictor of safety going down, and in many studies. But again, I think probably as quality experts in your field, you have probably experienced turnover rates that are related to burnout. Pre-COVID, burnout was expensive. 5% of all hospital revenue was lost to burnout. And again, that is turnover, that is mistakes that are made because people are tired and burned out. And physicians are becoming burned out at record levels. And again, this was before COVID. Do you mind advancing, Patty? So before COVID, 54% of physicians said they were experiencing burnout, and 63% of RNs. Now, these are the main drivers of quality on the healthcare team. So if you imagine that this was before COVID, and then we add all these other changes. So the next slide will look at what the changes are for COVID coming. So COVID is new to us, and it has drastically changed our whole world. Everyone in healthcare, everyone in the world has been affected by COVID in some way. So in a large study, they found that 83% of nurses during COVID are experiencing burnout, and 61% of these said that they are likely to leave their current position or specialty. Think of the cost that is going to happen if that many nurses and physicians leave their facility. The impact it will have on quality, on financial cost, on just the culture of your organizations. And again, 67% said that they're planning to leave their facility or industry altogether, and almost 3/4 of respondents said they are currently experiencing high levels of anxiety and emotional stress. And this really, when you say 74% of healthcare professionals are having high levels of anxiety and emotional stress, this puts a huge strain on healthcare systems. Patty, can you advance, please? So this probably isn't new to you quality experts, but there is a high personal cost for caregivers. Physicians are having higher risk of suicide, substance abuse, relationship issues, depression, anxiety, feelings of worthlessness, and doubt. Please advance, Patty. So what is burnout? Again, stress is inherent in life. Bricks of stress make us grow. But when we have prolonged response to chronic and emotional stressors, and the stressors just won't go away, then we have burnout. Now, burnout is defined by 3 dimensions. One is of exhaustion. Now, this exhaustion is physical, emotion, spiritual, complete exhaustion. And what we see a lot is cynicism with detachment. So sometimes you'll see nurses or physicians who are sarcastic about their patients, but it is to build a wall so they can protect themselves, but it definitely affects quality when you see this cynicism. Sometimes it is called depersonalization. It is where that other human being says, I should care about you, and I just don't. I don't have anything left in me. I'm empty. And so what they do is they build a little wall where they don't have to feel the stressors, but behind that wall, they're isolated and alone. So what happens is inefficiency. And inefficiency definitely affects the workflow, affects quality overall. And Patty, would you please advance? So I'm sure you're seeing it in your organizations, the signs of burnout. It's emotional exhaustion. It's that depersonalization, that looking at that person and just not being able to feel compassion for them, not being able to see them as an individual human being, just being able to see them as a label, a diagnosis, a room number. What happens with the caregiver is that they experience anxiety and depression. Then it's a loop. It's just a dangerous spiral. They end up having a lack of personal accomplishment. Then they feel a lack of professional fulfillment. They can even have anger and resentment towards patients, and this then causes guilt. I should be better. I should be able to handle this. I shouldn't be so tired. But then you go back to that depersonalization. So it's just a chronic loop that can just really wear down on caregivers and just make them feel so much doubt in what they can do. Can you advance, Patty? So what does it look like? You see it. Again, it is that physical, emotional, and mental exhaustion. And I'm sharing several different resources that are similar, but they're saying much the same thing. But what it feels like for staff members is that they have a dread over returning for a shift. I actually had a nurse tell me recently, I cried the day before I had to return, just knowing what I was going to have to deal with. That compassion fatigue, where they're just not able to fully connect with the other human beings. What all of this does. I mean, this really is a moral injury for the caregiver, and what they want to do, their purpose doesn't connect with how they're feeling. And so what they have is sadness, depression, anxiety, and feelings of self-doubt. And the important thing in this study is it's rampant. It is rampant in healthcare providers. And again, this is a study that was done well before COVID. And can you advance, Patty? I love this quote. This is by Holly Way. She was one of the physicians and at the epicenter of the original COVID outbreak. And she said nurses, but again, this applies for physicians as well. Nurses in the front lines are like warriors in the war. While there might not be visible bullets going through, they are fighting the invisible virus. They need both physical and psychological armors, which leaders of all levels should provide. What I want to say about this quote is think about it. What was the scariest thing about COVID? And really that it's unknown. When you have a horror movie, think about it, the scary movies. And I'm not somebody who likes scary movies. But when you have scary movies, what is the most frightening? It is the ones that are unknown. It is the ghost in the closet, the monster under the bed, the shark under the waters. And one thing about this quote, we're going to talk about this in more detail, is that our healthcare providers need physical and psychological armors. So we talk in healthcare about safety and quality, and it really is with our healthcare workers, they need physical safety, but they also need psychological safety. And then here's the important part, which leaders should help provide. Okay, Patty, could you please advance? So I'm sure you know this from a personal level and you see it in your staff, but being a healthcare professional is stressful. And in COVID, there are additional stressors. Some of the stressors, and we do at Interactive Quality, we do a session called Resiliency in the time of COVID. And we hear common themes. And one is that providers are worried about taking COVID home to family. They're afraid of dying, but they're even more afraid of loved ones dying. And financial stressors, people have been laid off, they've been furloughed, they've been fired. Many organizations have been worried about running out of PPE. And again, that moral injury, it's that I need to take care of people, but then I have all these stressors. One example of moral injury in the organization that I work for is we had a limited visitation policy. And it was so hard on all of us to tell the loved ones they could not come in. That was at total odds with, as a caregiver, what we want to do. Childcare issues. You have children who have been home and you have to take care of them, but you also have to work. So again, what is most important? How do I make these decisions? Homeschooling and feelings of guilt. I've heard so many providers, so many nurses tell me, I feel guilty that I can't be with my family. I feel guilty that I feel resentment towards coming to work. I feel guilty that we haven't been hit as hard as other people. So I'd like to take just a couple of seconds, and as healthcare professionals, you personally have experienced stress related to COVID, and you hear your staff members expressing stress and anxieties. Would you take a few minutes and just write in the chat, what are some of the stressors that you have been experiencing? And then we'll kind of talk about those. They may be some of the ones that we have found at Interactive Quality, but they may be ones that are unique to your, but please take a few minutes. But one thing I will tell you, when we do our sessions with staff and providers, one thing that's very important is that the providers, they're not worried about themselves. They are worried about others. And providers, nurses, physicians, they are a group of people at the core of their being. What they want to do day after day is take care of people and keep people safe, help people be better. Could you please advance the slide, Patty?
Sure, Audrey, and we do have a few comments.
And I'm not able to see those, I'm sorry.
No problem, they're in the questions frame. So somebody typed in, worried that I'm not doing enough to help my kids with school.
And in that, I hear worries about kids, and I also hear guilt. Guilt that you want to be there for your children, but you also have to be there for your profession. And again, that creates some of that moral injury. I'm not able to do everything that I need to do to keep everyone safe and functioning optimally. Very common themes. And what else was there, Patty?
Not knowing how bad it will be.
The unknown. Again, it's that monster under the bed. It's that shark under the water. None of us know. When we know, then we can deal with it. But there is so much about COVID that is still completely unknown.
Next one was meeting everyone's expectations, work and family.
Again, that guilt, that moral injury. So you kind of hear some of these common themes that go on, and that's what we've seen overall. And so how do we battle all of these stressors, these conflicts of who we want to be, what we know, our fears, and how do we move forward? Well, as quality professionals, it's very important that we create a healthy work environment for our staff and our providers. Very first, and if you can advance it one more time, I just want to show Maslow's hierarchy here, and all of you are very aware of this. But I think one thing with COVID is we've learned this has really jerked the rug out from all of us as far as feeling safety. There was a world that we knew was secure. We all knew what to expect. And all of a sudden, that certainty is gone. So to have a healthy work environment, we first have to have physical and psychological safety. Without that, we cannot connect to meaning and purpose, and we cannot connect with autonomy and control. And many of the people that I deal with say, I don't feel like I have a sense of control over this. I feel like it's controlling me. So the important part about this, as we know, is that if we cannot provide our staff with some semblance of physical and psychological safety, they are not going to be able to do the quality we will not be able to have the safety in our organizations that we need to provide the care. And do you mind advancing, Patty? So again, as leaders, what drives engagement? Workload and job demands. You hear it, the stressors. When the efficiencies and resources, when the nurse has to do 10 clicks on the computer versus 3. Again, you're going to see this in many of the research studies, meaning and work. when the times get tough, the one thing that is really going to sustain our providers is connecting to that purpose. Why do I do the work that I do? What this does is it also cuts down on that moral injury. When you connect the person, why they do the work, they make a difference, they make an impact, they are able to have less stress and burnout. A culture and values, they need to be aligned in an organization. And again, here's that the same wording, control and flexibility. And many of us have millennials in our workforce, and it's so important for them to feel like they have some sense of control, some flexibility. And then again, social support and community at work, that people do not feel left out, excluded, that there's not gossip and negativity. A work-life integration, and that's becoming more and more important. I've been a workaholic most of my life, and just in my 50s, I'm learning that really there needs to be that balance between work and life. Do you mind advancing? So again, when individuals are burned out, they lose their ability to cope. Now, I have a friend of mine, Ambra, and she has a 7-year-old daughter who has severe anxiety even at a young age. And she goes to counseling and they teach her how to cope. And a couple of weeks ago, she came home and she said, Mom, I'm all out of copes. And she cried. And that just resonated with me because I can hear a child saying, I'm all out of copes, but haven't all of us had days where we are all out of copes? And again, stress can help move us, it can help us keep us safe. But if we have so much stress that we lose our ability to cope, we are no longer functional. Can you move? Okay. On the other hand, when we are resilient, when we are able to bounce back, we interact with our environment in an optimistic and adaptive way. It means we change and we grow and we become better. And we are able to focus on purpose, on human connection and personal growth. And I hear that over and over again, those three things, that when you have a purpose and you connect with it, and when you are able to connect with other human beings fully, then you are able to grow and be more resilient and able to cope with your environment. One more, Patty. So the good thing about resiliency is it can be learned. Some people are naturally resilient, but most of us are not. The research shows that people with a positive mindset are more resilient, that people who are able to adapt to change. This is a big one because before COVID, change was inherent in healthcare. After COVID, change is every day. Also important that people who are resilient are able to avoid judgment. So in our resiliency model, that's a big piece of, because again, if you think about it, every time you judge another human being, you call them a label in your mind, it puts a little brick of stress on your heart. And again, stress is okay in little bricks. When it builds up, that's really when we have the burnout. Again, so important that people have support, whether that is family, whether it is church, whether it's community, whether it is your coworkers at work. People with self-efficacy are also more resilient. Now, self-efficacy, I say I compare it to being a redwood. You see the picture of the redwood there. Redwoods are these amazing trees, hundreds of feet tall, hundreds of feet around, hundreds of years old, able to handle any storm. They've handled earthquakes and fires. But many people are like redwoods. They are those strong people who are not blown over by the strongest of winds. They're able to handle it. Now, how do redwoods stay so tall and so strong? Some people say, well, they have very deep roots. The opposite is true. Redwoods actually have very shallow roots, 4 to 6 feet deep, but they connect their roots and they work together as a team to stay strong. In fact, the strongest of the redwoods divert some of their nutrients to some of the weaker redwoods to help them. So think about it. On your unit, in your area, do you have redwoods? In your life, do you have redwoods? In my life, my mother is a redwood. She definitely taught me my values, my work ethic, and when I was wrong, she told me and helped me grow. So how many of you have redwoods that you work with? These are the people that no matter what is happening, they're able to see a better future in the past. They're able to do something that we're going to talk about here in a little bit called time bending, able to look back at the past, but be fully present in the present and able to look to the future to grow. Again, there's many studies about healthy lifestyle, getting enough sleep, eating good food, being able to have good relationships. All of these things can help you stay resilient as well. Okay, Patty. So again, I want to talk a little bit more about time bending, and this is one of my favorite concepts with resiliency. You probably know some people who are always complaining about, why do things always happen to me? I'm just so unlucky. I just have had some, you hear people that just are completely negative about what's happened in their life. But the truth about resiliency is it definitely is looking back at yesterday without regret, with looking at the good and the bad, then coming fully to the present and saying, what have I learned from that? But then, where am I going to be tomorrow and how can I get there? The important part of time bending is that resiliency is a choice. Life does not happen to us. Bad things happen to all people. All people go through struggles. And I think that's one thing, that's one positive thing of COVID is that we've all gone through this together. And so nobody has felt left out. And we're all having to learn how to be more resilient in the time of COVID. Okay, Patty. So this is another, you probably figured out I love quotes, but problems are to the mind what exercise is to the muscle. They toughen and make you strong. Now I do consulting, and I was doing some consulting in Gunnison, Colorado, which is beautiful, way up in the mountains. And this was last year before COVID, in July. And there were beautiful wildflowers. There was green, 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 and there were snow-capped peaks. And I'm driving up the mountain from 8,000 square feet above seawater to about 13,000. So I'm going up this mountain, and it's just gorgeous. And I become aware of all these cyclists, and they're just trudging up this mountain. And I mean, they're moving. And I drive past them, and I drive past a guy with a long gray ponytail, and I'm like, oh my gosh, he must be 65, and he's making it up that mountain. So I thought, oh, I can't even imagine what that would feel like to be able to do that, to be that physically robust. But I never got out of my car. I never got on a bicycle, and I would not be able to make it up that mountain without dying. So resiliency is much the same. You can't sit and say, I wish I was more resilient. I wish I could handle this. I wish this didn't bother. You can't wish it away. It takes conscious effort and work and exercise. And so when I get to our resiliency model, I'm really going to show you what the tools are, but they take conscious effort to work on them every day. Okay, Patty. So now I want to get to our resiliency model at Interactive Quality. And I want to tell you a little background because I've given you a ton of information on the background of resiliency. But I actually I spoke at a national conference back in 2018 on resiliency, and this was before we designed the model. And I was speaking about some efforts we had made on an emergency department project, and we had great strides in decreasing resilience, decreasing burnout and turnover. And I was speaking about that in Orlando, and I had a small group of 150 people. And after my presentation, I walked across the hall to see one of my favorite authors on resiliency speak. And there was over 1,000 people in this huge auditorium. And she's exceptional. She does a lot of research on millennials and how they handle burnout and stress. And again, this was before COVID. But then there were people asking questions. And one was a young nurse, and she said, I've only been a nurse 2 years. But I'm done. I'm burned out. I know the research. I see it. I feel it. I live it. But what do we do about it? Another middle-aged lady stood up and said, I'm seeing all my nurses just get burnt out and want to leave the profession. And what are some of the solutions? And so I went back to my hotel room, and my fiance is a physician, so he understands a lot of what goes on in healthcare. And I said, Tom, what is the solution? And he said, I don't know. So I went to sleep, or tried to, but I could not. And it kept going around in my mind. What is the solution? And then I woke up literally at 2 o'clock in the morning, and I shook Tom and I said, Tom, get up, get up. I need you to help me work on this. I get it. I get it. The solution is you give staff tools to help deal with burnout, with stress, but that's not enough. You have to have an important component where leaders are given tools on how to support their staff, how to help them deal with change in a positive way. And that is where Steady and Raise came from. By morning, now, of course, Tom was like, can we wait till morning and drink coffee? And I said, no, we have to do it right now. I've only done that to him a couple of times over the years, and he's gotten used to it. But by morning, we had the Steady Raise model. Okay, Patty. So the Steady model, again, is for staff. And it is a lot about human connections. It is, how do you cope with that moral distress? How do you cope with those labels, those irritations? The first thing you need to do is stories. Seek the story of each person. T is for turn around your thoughts. We all have negative thoughts about others and ourselves. How do we turn those around? E is for empathize. And again, empathy is so important in being able to connect with other humans. A is avoid judgment. As we discussed in the research, when people judge others, it adds stress to their life. D is don't take anything personally. And at Interactive Quality, we call it Q-tip. You need to Q-tip it. And Q-tip stands for quit taking it personally. And we'll talk more about that. But what's most important in the STEADY model is connecting back to purpose. And that is the why. You, what you do matters. You are enough. Your organization cares about you. Always connect back to purpose. Okay, Patty? So stories. Each person has a story. Now I'm going to tell you a story that changed, and I think really started me on this patient experience journey. I was a nurse at the time. I was a manager. It was years ago, and I worked in a busy clinic. And if you took care of everybody exactly as they needed, you could have time for a potty break. And it was actually a pre-admission clinic where I got people ready for surgery, had to get their health history, EKGs, teach them, get a chart together. And it was just, if you did it right, you could maybe have a quick lunch. If not, you're behind all day. So I got pretty good at redirecting people and getting people back on course and being very friendly with them. But one day I had an elderly couple come in, and the woman's name was Ruth, and she was in a wheelchair. And her husband was very, they were both in their 80s, but he, by contrast, was very tall and robust. He had a tan. He wore shorts and tennis shoes. So obviously, had some athletic ability, even in his 80s, and he was very talkative. So every time I would ask Ruth a question, he would answer with a joke. For example, they love to play golf, or he loved to play golf, and their dog's name was Putter. So it was very entertaining, but I realized that we were really getting behind and not getting the health history done, not getting the med list completed. So I kept trying to, I hear you. Well, I really better get her health history. I respect your time, all the things that had worked before, and they just didn't. He just kept getting off topic. So finally, I think he must could tell that I was becoming a little irritated. And so he stopped me and became serious. And he said, Audrey, may I show you something? And in my mind, I was thinking, well, of course, if it'll move us along and get you done. And that really was my thought. He reached back into his back pocket and pulled out his wallet. He went through the items in his wallet and pulled out, of all things, a small black and white photograph with jagged edges. Now, some of you may remember those from your grandparents. I'm definitely old enough, I do. But I had not seen one of these in years. Small photograph with the jagged edges. And he showed it to me. And on the front of this photograph, of all things, was a young, beautiful couple on a trapeze in shining outfits looking over a huge crowd. I knew instantly that this was Ruth and her husband. He said, Audrey, you want to know her health history. You want to know her medication list. I understand that. But what I want you to know is I met Ruth when she was 16. I've been with her my whole life. We've traveled the world. We had an amazing career. We've performed in front of kings and queens. We went to every country in the world. And yes, now we're old. We're old. I'll tell you all the information. Ruth has many health issues. I have many health issues. But what I need you to know, Audrey, and at this point, he taps the photograph. What I need you to know, Audrey, is we are still here. That resonated with me, and I've never forgotten them. And it made me think, every person has a story that we don't see. Every person, and it may not be as dramatic as a trapeze artist, but every person is not necessarily just an old person. Not everybody is just a knee replacement. And it made me think about human beings in a whole different way. And he taught me a very valuable lesson. One of the tools in seeking stories is from Mary Colarutis in a book that I love, and it's called See Me as a Person. And the tool is simply called wondering. And that basically is where you look at every human being, and and you think, who are they? What was their life? What were they like? Do they have children? Do they have a belief in God? Be curious about them. Wonder what is beyond the behavior. Sometimes our patients and our staff even demonstrate behavior that is not very functional, that is not very positive, that is even angry. And again, when we wonder what is beyond that behavior, we also, in our classes, we teach a model called Ways of Being, and that is from a book from the Arbiter Institute that we use as well. And again, it basically talks about seeing people as persons versus people as objects. Okay. Can you move on, Patty? So T is for turnaround thoughts. And the main thing of this is to teach yourself and your staff, you have control of your thoughts. Your thoughts don't control you. Again, we all have negative thoughts. We have negative thoughts about others, and we have negative thoughts about ourselves. I am not enough. They are mean. We have these negative thoughts. But when you're aware of them, you can just grab them. You can grab them and consciously reframe them and turn them around to something more positive. I am enough. I can do this. They're not being mean. They're just having a rough day. I need to have grace with them. Always assume good intent. And my staff will tease me. I'll walk down the hall and I'll be bobbing my head, and I don't have a tick. In my head, I'm saying a little mantra: assume good intent. Assume good intent. Again, people don't mean to come to work and being annoying. Patients don't come to and mean to be demanding. Again, assume good intent. I think a lot of you are familiar with the circle of influence versus circle of control by Stephen Covey. But again, how we turn around our thoughts is focusing on what we can and we will do, not what we wish, what we don't have control over. So we teach a lot about that in our resiliency model training at Interactive Quality. Okay, Patty? Empathy is so important. And again, empathy is about being with. It takes no emotional involvement. It is accepting that person where they are, but it's not fixing it. And this is important, and this ties into the leadership model too, because we can be with somebody, we can understand their stressors, but we can't fix everything. We can't fix that person dying of cancer. We can't fix that coworker who's going through a divorce. So simply being with and accepting them where they are. We teach a lot about empathetic statements at Interactive Quality, and empathetic statements are taking that person's frustration or fear and just acknowledging it. Simply for a patient, I understand it's frustrating to wait longer than you expected. I know all of this is very overwhelming. I know you must be a little scared right now. And what we found is when we acknowledge their fears and we simply are with them, they are able to feel cared about and feel that connection as a person. And it's very important that our staff develop self-awareness and emotional maturity, that they are able to see that other person, not become defensive, not jump into what they're going through, but simply be with. Okay, Patty. As we talked about judgment, every time you judge another human being, it's a brick of stress on your heart. Remember, bricks of stress build up, they wall you in, and they can burn you to a crisp, leave you lonely and isolated, and lead to burnout. Again, how do we see other people? Do we see them as an equally worthy human being? Or do we see them as a label? They're stupid, they're ugly, they're inefficient, they're a whiner. We label people. Again, it's developing that self-awareness where you can grab those thoughts and avoid judgment. Again, be aware of the labels that you put on people. Okay, Patty? And I'm just giving you just a little taste. In an hour, there's no way we can cover this, but please know that at Interactive Quality, we have sessions that really dive into each of these and to take away even more useful tools. One of my favorite parts of study is don't take anything personally. Again, Q-tip. And we use that as a verb in my organization. We say, you need to Q-tip that. Again, Q-tip stands for quit taking it personally. Again, how you Q-tip? Again, you need to use wonder. When something feels personal, I feel like they're attacking me personal. I feel like they're mad at me. Again, wonder about them. I wonder what's going on with them today. I wonder what's going on. Again, always assume good intent. Very important. Most of the time, it's not about you. I know when I was younger, I would think, oh my gosh, they don't like me. They're upset at me. And finally, as I've gotten older, I realized, people are just all going through their own stuff. Everybody has their own worries, their own stressors, their own fears, and it's not about me. It's just about their own stuff. I've got my own stuff. Everybody else has their own stuff. And once we realize that, then we can not take it personally. Very important to is to help your staff understand the importance of having respectful conversation no matter what is going on. So the other person is angry, we still have to have a calm tone and respectful. And that takes a lot of work. It takes that self-awareness. It takes developing that emotional maturity as you go. Okay, Patty? Again, at the end of steady, most importantly is you. You have a purpose. What you do matters. You make a difference. You are enough. You can do this. And if you are feeling stress and burnout, you are not alone. It is rampant. It is everywhere. But you are not alone. And your organizations and your leaders, we care about you. Most important message, always connect back to what they do matters. Okay, so in a nutshell, that's steady. And now we're going to move forward to raise. Again, the whole thing, and let me, one more slide. Sorry, I'm not used to not having control of the slides. And I think that's probably my fault on that, so I apologize for that. Can we go back one slide, Patty? Again, teaching staff tools on how they can connect back to why they can make a difference. The importance of relationships, that connection with other humans, but also help your staff develop emotional hygiene. And again, all of this contributes to safe, quality patient care in our organizations. We do a lot of teaching about the power of gratitude. Again, I keep a gratitude journal every night. Every night I go to bed, I write down 3 things I'm grateful for. And actually, I got this idea from Montel Williams years ago. I saw him as a speaker at a conference, and it has really made such a difference that just writing down or expressing that gratitude verbally, self-reflection, getting in the habit of looking at yourself and saying, I'm good at this. I really am good at this. And yes, these are my weaknesses, but this is what I'm good at, and I'm going to do more of that. Prayer, meditation, the power of deep breathing, so important. And again, those healthy habits. Okay, Patty, now I'm ready. So steady and raise, again, go hand in hand. Steady is for staff, the tools to help them be able to handle the stressors day to day and to develop the emotional maturity to be able to empathize and not take things personally. But that can only succeed if leaders take a very proactive role in supporting their staff, and that is the RAISE model. Okay, Patty? So again, this is not rocket science. You guys know this. I do a session that's called Leaders on Fire, because my theory is if you're a leader, lead with passion, grow people, help them be better. And in the time of COVID, help them develop great skills to be able to deal with the stressors that we have. So leaders drive culture. I've heard this so many times. Look around at your culture. If you like it, that's because of great leadership. If you're not real happy with it, if there's negativity, if there's a lot of gossip, if there's a lot of turnover, then look at your leaders. You really need to look at, because leaders drive culture. Okay, Patty. So RAISE, again, is the leadership model, and that stands for relationship, acknowledge struggles, investigate causes of stress, support staff, and evolve. And again, just giving you a snippet today, but on relationship, if you as a leader, you cannot skip this step. You will not be able to gain the trust or the respect of your staff without relationships. And you all know this and experience it all day. But once you have a strong, trusting relationship, you can accomplish anything. Now, you probably have staff who come to you and they have stressors. They may be going through a divorce. They're upset about a workload. You may have patients that are stressful and demanding to them. So it's very important that we acknowledge struggles. Now, remember we talked about empathy is about being with and not fixing it. So is acknowledging struggles. This is where you acknowledge, I hear you're having a rough time, but it's not necessarily that you fix it. You simply, now there are some things you can fix, but as a leader, you can't fix everything. And knowing that will help you be less stressed out. What your role is to help coach others in what they need to do to be able to handle the stressors that happen. As leaders, we also need to investigate causes of stress. So this is redundancies, this is gaps in workflow, this is workflow inefficiencies, this is charting errors. The world in healthcare is very complex now, and there are so many demands put upon our providers, our nurses, our physicians. So it is important that as leaders, we truly look at the causes of stress. We can't just have the human connection. We also have to help decrease the complexities of the computer systems, of how different systems interact with each other. We all have these issues, and I know they're inherent in healthcare. It's very important that we support our staff, support our physicians. Now, what is support? Support is recognition, celebration. So it's thank you cards. It's making sure that you catch them doing it right 90% of the time. And when they're not doing it right, you have a gentle conversation and help coach them on how to be better. And support is more than anything, coach, 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 coach. And coach isn't just, I want you to do better. Coach is, here's what you're doing right, and here's how to do more of it. Coaching is helping them grow. Again, what matters most to our providers and our nurses is that they have a sense of purpose, that they feel appreciated, that they feel that what they do matters. And as leaders, if we can support them and coach them, then we can evolve. E is for evolve. Change is inherent in healthcare, always will be. Healthcare systems that stay the same and do not change, they will not have quality, they will not have safety, they will not have good patient experience, and they will not have financial indicators that will help them sustain their organization. So evolve is necessary. People don't like change. So as leaders, one of the most important roles we have is to help our staff and our providers be able to change and grow in a healthy way that is less stressful to them and to us. And again, many of you are familiar with Simon Sinek. Always start with the why. Once they know why, then they will jump in. And when you have an implementation effort where everybody is on board, we implemented bedside reporting at an organization I worked at, and everybody got on board because they understood the benefits to the patient and to the staff. And they went from the 6th percentile in responsiveness to the 89th, and that was at Peterson Health in Kerrville. But everybody had a buy-in, and that implementation wasn't scary. That implementation was exciting, and it was fun. So relationship, acknowledge struggles, investigate causes of stress, support your staff, and evolve. Help them change in a healthy way. Okay, Patty? So again, I work at a small 125-bed hospital in my day job, and we have 1,200 employees. We have been working really hard on developing our leaders and helping our staff be more resilient. We won the coveted Governor's Award this year at Peterson Health, and that basically is the Texas equivalent of the Baldrige. This organization is going to apply for the Baldrige in 2021. They went from a Leapfrog C a couple of years ago in quality to Leapfrog A. Again, how did they do that? Our focus has been on our staff, on our providers. When we support them and help decrease their stressors, that's when we really move ahead in quality. We have won the Healthgrade's Outstanding Patient Experience Award for the past 4 years, and I'm very excited about that, and I'm ready. We're going for 5 years. Again, we just got our results back on the employee engagement survey, and we're at the 91st percentile nationally for 2020. Again, we had 87% of all of our staff take the survey, and we ranked at the 91st percentile. We're also above the 90th percentile in our physician engagement survey. So the outcomes are pretty clear. We started our path on resiliency there back in 2017. And again, that during my time with them is when the Steady and Raise model were developed. Okay, Patty? So again, one last quote. The greatest glory in living lies not in never falling, but in rising every time we fall. And in a nutshell, that's what Steady and Raise is all about. We're all going to fall at different times. We're going to fall as a society. We're going to fall as an individual. We're going to fall as an organization. COVID has been a great stressor. We have fallen in many ways, but you can already see as a nation, as a state, we are rising. We are becoming less afraid. We're dealing with the financial insecurities. Our staff are learning how to use the PPE correctly. We are getting over some of our fears. We are rising. Okay, Patty. So I want to end with, we understand that burnout negatively affects your outcomes. It decreases the quality, the safety in your organization. But the good news is that resiliency can be learned and it can be woven into your culture and your values. Purpose is powerful. It's essential. The only way that Steady and Raise works is when leaders support and guide their staff, that they consciously work to build each person to help them be able to handle the challenges and to give them the tools to be able to handle the stressors. At Interactive Quality, Steady and Raise is an evidence-based solution. We develop individual resiliency resources as well as organizational. So again, go forth, stay steady, and it's been my pleasure to be with you today, and I'll take any questions that we have time for. Please feel free to reach out to me, and I'm on LinkedIn, and you can also reach me at Interactive Quality. Beth Guyton is my colleague at Interactive Quality, and she and I would love to talk with you about Steady and Raise further.
Thank you very much, Audrey. We don't have any questions yet, but we have some very nice comments. Excellent, timely presentation. Thank you. And congratulations from all of those awards you guys won. It's very impressive work. So if anybody has questions, please type them into the chat and we will take them. I know from your talk, I wrote down a few things, Audrey, that I'm definitely going to start using the Q-tip. And I just bought a journal the other day, didn't know what I was going to do with it, but it's now going to become my gratitude journal. So thank you for sharing those tips with us.
Thank you. It has been my pleasure, and I look forward to visiting with anyone who would like to know more about Steady and Raise. Thank you.
Thank you again, Audrey. We really appreciate you sharing with us. Lots of references. So our next speaker I will introduce is Winji Mayo. She's the Senior Executive Vice President and Chief Experience Officer at Texas Health Resources. In that role, she brings consumer, and operational experience to the company's core business transformation and new business creation, including research and development and strategy for Texas Health. I am going to give you control, Winji, and hopefully it will work.
Well, good morning, everybody. First of all, thank you for having me. And Audrey, congratulations on all the work. You're so passionate about what you do, and that passion definitely shows. After those outcomes, I don't know if I have any more impressive outcomes to share, so I think I should have asked to go first in this series. But again, it's great to be with you all today. Thank you for having me, and we'll go ahead and get started. So many of you are very familiar with Texas Health. We have affiliations. We're a large health system with over 350 points of access, and we have affiliations with numerous organizations from all aspects of the healthcare industry. And these relationships, along with our major initiatives and quality programs, all have a collective aim to provide employers and consumers in North Texas with more affordable, high quality, and seamless care. So a little bit about my role. You know, people are like, I don't really understand what exactly your role is, and and to me, here's how I describe it. It's fairly simple. The way that we all experience life is a little different, and the way our communities experience healthcare and their expectations have changed. So for us to truly live our mission at Texas Health of improving the health of the people in the communities we serve, we have to pivot how we provide that care and really deeply understand our consumers to really provide care in a way that they'd like to have it in order to, yes, delight them from a patient experience standpoint, but also engage them in a way that we truly improve their health outcomes. And that's what we focus on, and my role is every day here at Texas Health. From a business perspective, I wake up every day and think about ways to ensure that Texas Health doesn't become the blockbuster to somebody else's Netflix. I think that's the simplest way to describe it. We all know there's a lot of disruption coming in healthcare, and that sometimes health systems can be a little slow to change. And so my role is really to accelerate that change when appropriate and ensure that we are continuing to evolve the organization in the way that our patients and our community really expects and deserves. So I am actually going to start a little bit because one of our core competencies is understanding your consumer and your customer. I'd like to really understand who's on this webinar today a little bit. So I do have two questions in the poll. The first is, what is your primary function within your organization? So if you'll participate in this and vote, we'll give it a minute, and Patty, let me know.
Sure, the answers are still coming in. We'll give it another 15 seconds or so. Okay, I'm going to close the poll. And do you see the results?
Yes,
okay.
I do. So we've got almost half in a hospital-based quality or patient safety, about a third in system-based, and then some of you are clinical department leaders and some in other. So a majority of you, a super majority, definitely in hospital and system-based quality or patient safety roles. Great, so thanks for that. We also have a second question for you, and as she puts the second question up, I'm going to preface this by saying there are no wrong answers to this. This is truly what speaks to you today. What spirit animal do you most identify with? And this is in life. This is not, well, am I trying to answer for professional or personal? This is just what speaks to you in this moment today.
Okay, we'll leave the poll open for about another 10 seconds. Please vote. Okay, I'm going to close the poll.
All right, so most popular, we've got dolphins and owls, about a third, a little over a third for owls. Owls are leading the charge here. Dolphins, and then we've got some really cunning foxes that I know I would not want to play poker with because this is not my skill set for sure. And some who are very action oriented, and we definitely need all those individuals within our organization. So thank you for that. Hopefully that gave you a little chuckle, and it really does give me a better understanding of who's out there, and I really appreciate that. So I was asked to share with you today my perspective on how patient experience and patient safety come together, and so oftentimes I'm asked what we should focus on most or first. And to me, the entirety of the patient journey shapes a patient's experience with us, and clearly patient safety is the cornerstone of that experience. But I've always said that really the interaction and the experience component and the safety component really are a tango, right? You can't have one without the other. And at Texas Health, we believe that by understanding each individual's unique situation, we can provide an optimal patient experience, which includes improved patient safety. And I'll share a little bit about our journey on this path, but first, since this is about the patient and our consumer in the community, I want to start with Annie's story. Annie is a woman I met who lives in Dallas-Fort Worth. Her story starts much like probably many of our stories do. She was a good student, worked hard, and got a bachelor's and master's degree. She worked for several years and then had the courage to start her own nonprofit organization. She built it into a successful company for over a decade. And like many smart, strong women, Annie was also the person her family relied on. Her dad had chronic diseases for many years that she helped manage. After a while, her dad's health worsened and he required dialysis. Annie was able to juggle her schedule and his needs, including driving him back and forth to the dialysis center, but it was definitely stressful. She was spending several evenings a week in the car. As many of you know, Dallas traffic can be really bad, especially pre-COVID. And her dad lived across town where she had grown up. And she was unable to do many of the things that were part of our normal lives, like keeping a normal exercise routine and connecting with friends. One day, Annie went to work to pick up her dad from the dialysis center, only to find out he wasn't there. He had suffered a stroke during his treatment and was in the hospital. He survived the acute episode, but his baseline health had drastically deteriorated. He required more and more care. Annie was there, ensuring that his needs were met. She drove her dad to all his appointments. She got his prescriptions from the pharmacy. She cooked his meals. She became his full-time caregiver. She did what many of us as daughters would do in her situation. She simply took care of her dad. And like many of our dads, Annie's dad was sometimes brutally honest and would say to her, "You didn't just come up here looking like that." And Annie would think, "Well, Daddy, you'll just have to take me as I am, because it's either be here with you or go get my hair done." I met Annie about 8 weeks after her father passed away. She was spent, literally and figuratively. In giving her father what he needed, she had to give up her business. She declared medical bankruptcy. She bravely admitted that she looked in the mirror one day and couldn't recognize the person looking back at her, and that she didn't know what was next. Most important of all, she told us that even with all she had gone through, she would have made the exact same choices. I think of Annie a lot. She did everything right. How did the system fail her? Did she not know the resources that were available? My personal story isn't so different from Annie's. I grew up in the cornfields of Illinois, and I had the opportunity to go to college with aspirations of doing basic science research and becoming a physician. I started in a basic science research lab and ultimately ended up at the Human Genome Project. But a chance opportunity at the School of Public Health sounded more interesting than the data analytics I was doing. And by the way, it paid 50 cents an hour more, and as a poor college student, that definitely didn't hurt. So I took a leap of faith. So just like Annie, I got a master's degree and began a career in not-for-profit healthcare. 18 years later, having built a successful career first in hospital operations and now within an integrated delivery system, I met Annie. And I had to do my own soul searching. What could we have done, a $5 billion not-for-profit faith-based health system in the fourth largest metropolitan area in the country? How could Texas Health have supported her better? And what was I, as someone who is privileged enough to sit in the C-suite of such an organization, going to do about it? How did we let this happen? The answer is fairly simple. All of you know this. Annie fundamentally ended up in her situation because her dad's providers were focused on treating the illness each time he got sick. As you all know, our healthcare system is by and large an episodic sick care system. Health insurance covers you in case you get sick. Sure, it covers some basic screenings, but not actual interventions to improve health. And the people who provide the health care, doctors, hospitals, ASCs, others, have been a cottage industry for a long time. Clearly, there has been major consolidation over the past 20 years, but it's still very fragmented. And fragmentation causes inefficiencies and variability in quality. It's been widely published that the U.S. spends more for healthcare than any other developed country. And yet, our health outcomes are in the bottom quartile. What's more interesting, however, is that if you take the amount developed countries spend on both medical care and support, whether that's social support for a mom for a year after she's given birth in France, or paying family members for providing care to their loved ones, what we find is that the U.S. actually spends close to the median of what other developed countries spend. Now, some argue that we spend more because we have more advanced care and that these advances cause us to live longer and better. But the fundamental truth is, in the United States, your zip code is still much more predictive of your overall health and life expectancy than your genetic code. I'm sure you've seen this graph of Dallas County, where individuals just a few miles apart have very different life expectancy. I apologize, I don't think the animations worked on this slide. So the overlay on this is one of my favorites. This is actually a map of Baltimore County, which is very similar to the Dallas County map underneath this, where helpful people have taken the life expectancies from other countries and overlaid them onto a similar map of Baltimore County. And what you can see here is you can live in Roland Park up top, which is a very affluent area, and you have life expectancy like Japan. And just next door, you have life expectancy more like Nicaragua and or places like Pakistan and Namibia. We know that treating social determinants and environmental factors upstream from sick care is an essential part of improving quality and quantity of life in America today. And I want to be clear that clinical breakthroughs and traditional clinical care in hospitals and clinics are essential to advancing the human condition, and I will always be in awe of the people who push the boundaries of modern medicine and continue to fight and cure and prevent disease. In fact, I miss being in a hospital every day. But we must also have the same intellectual curiosity, research, funding, and desire to understand and solve the social factors that impact health and impede our ability to live our best lives. It's both and, not either or. Because if we don't tackle both sides of the equation, costs will continue to rise and we will never have the quality outcomes that we want. And it is us, the individual consumer, that is bearing more of the burden of this cost. This graph shows the growth of high deductible health plans in the US since 2009. For many Americans, this may be the only option available to them from their employer. Think about your own health plans and your own choices as benefits and how your deductibles have changed over the past several years. Now, some choose these high deductible plans because they have lower monthly premiums. This seems great until you understand how these types of plans affect choices that families make outside of healthcare. And I want to introduce you now to another individual I met, Aaron. Aaron is a dad who lives in the suburbs of DFW. He and his wife are both teachers, and they purchase health insurance through their school for themselves and their 3 boys. Up until several years ago, they purchased a family plan that had a combined deductible of a few $1,000s. Last year, their health plan changed. Instead of a combined family deductible, they now had to meet a $5,000 deductible for each member of his family. That means that they needed to have $25,000 set aside just in case something happened to them during the year. When I met Aaron, it was springtime, and he was trying to decide, did he take his family to Disney World and chance the fact that a member of his family might get sick between then and the end of the year? or skip the family vacation just to be safe. By the way, the out-of-pocket max for Erin's plan, $40,000. Let me say that again. The out-of-pocket max for Erin's plan was $40,000. It's remarkable that everyone in Erin's family is healthy, yet healthcare costs are still factoring in their life's decisions and hindering their ability to live life to the fullest. And I would argue in some cases, hindering their ability to seek care when they need. Erin's situation is very different from Annie's, but in general, our healthcare system treats them both the same. If they or one of their family members gets sick, the care we provide is roughly similar. And we pride ourselves on this quote-unquote best practice care. But our clinical research has shown us that best practice care may not be so best practice or evidence-based depending on who you are. We are learning that drug efficacy can vary between men and women, across ethnic groups and genetic markers. And in some cases, best practice can be more harmful than helpful. The same is true on the social determinant side of the equation. Some of us live in food deserts or have beautiful neighborhoods that lack sidewalks for easy movement and exercise. Some simply can't afford the basics. There are church groups in my community, and I'm sure in yours, who have support groups who compare medication prescriptions and figure out how to split up filling the prescriptions because taking half of a medication is better than none at all. And when their doctor asks them, "Are you taking your medications?" the truthful answer is, "Well, yes, I am taking my medications," because they don't want to be labeled as a non-compliant patient, and they don't want to have the shame of admitting that they cannot afford all of their medications. But it's not always about resources. I've talked with doctors, pilots, lawyers who refuse to seek care for a myriad of conditions ranging from back pain to mental health because they are scared that it will impact their ability to make a living. So before I keep going, I'm going to pose a question to you again through our interactive poll. And I'm going to two questions. The first is medication administration and or medication reconciliation in the top five priorities of your patient safety initiatives? Simply yes or no.
The answers are coming in. We'll give it another 10 seconds and then we'll close the poll. I will close the poll now.
Not surprising, over 3/4 of you, medication reconciliation or medication administration is in your top priorities. So the second question, how many of you can cite an example where a patient withheld critical information which led to an unfortunate outcome or an adverse event?
We'll give it another 10 seconds. And I'll close the poll.
Again, simple answer and same breakdown. About 3/4 of you can say yes to that situation. And so here's my question for you, and this is not part of the poll. When you look and reflect on your patient safety and quality action plans, how many of those action plans address some of the fundamental questions that we've talked about today in terms of why these medication reconciliation events occur and why some of the adverse events occur? Right? How many times have you seen this situation, and how many of the initiatives that you're working on are focused on these topics? This becomes a more pertinent question as we embrace the acceleration of new channels of care as well, such as virtual visits and telemedicine. I'm not going to ask a poll question of who has expanded virtual health in the past 6 months. I think we all know the answer to that. What I will ask is how many of you have done a proactive risk assessment or scenario planning to identify new patient safety risks related to these new channels of care and begun monitoring for these risks? And what types of events in these new settings should be reported as new misses and true safety events in the future? In a lot of these cases, and in most cases related to patient safety and quality, the answer to truly improving patient safety is a mixture of clinical, social, and environmental factors. And they are all intertwined. And yet we still treat them as separate, independent things that we relegate to different parts of the system. And we do that across the board. Hospital care versus ambulatory care, sick care versus preventative care, clinical research versus social determinants. I would argue that rather than solving 3 separate single variable equations, we need to solve one very complicated multivariable equation, because patients don't see it as separate departments and separate things with separate patient safety and quality, with separate safety, patient, and quality performance improvement plans. And they certainly don't experience us that way either. The good news is we are now at a time where technology and computing will allow us to ask and answer some of these complex questions. This was not always the case. I still remember my first few weeks in a hospital. I remember thinking, I have more data about the soap in the soap factory I worked in high school than we do about what happens in our hospital every day. How can we be able to accurately measure things like electrical current traveling through a cell or model release rates of chemotherapy agents from different polymers, but not know what the rate-limiting step is for discharging various types of patients from our hospital? How can Starbucks know exactly how and when to get you to buy more coffee? But we still struggle with getting people to cancer screenings and adhering to a medication regimen. With the advent of electronic medical records, real-time location services, natural language processing, and computing capacity to ingest and analyze large, complex data sets, we can begin to answer these questions, and we can begin to connect the dots across our system and entire communities. I hope soon we will be able to identify the optimal clinical intervention based on their personal genomics, environment, and predisposed preferences and behaviors, and be able to couple that clinical intervention with other supportive care elements both before and after care to optimize the probability for a great outcome. Said a different way, how could we have understood the entire family situation between Annie and her dad, or Aaron and his family, and provided holistic options that ensure they received safe and effective care where and when they needed it? Coupling this new availability of data and analytics with human superpowers of curiosity, empathy, and problem solving to deeply understand our patients will provide us the ability to curate a healthcare experience, both clinical and non-clinical, that is as effective as Amazon is in suggesting products to you. And maybe I'm the only one that is incredibly impressionable and always says, wow, how did they know that I needed that? And lo and behold, it ends up in my cart. Anyway, it will require us to walk in others' shoes in a deep, meaningful way. And it will also require collaborations larger than we have seen before with people with whom we have yet to meet. This requires us to genuinely, authentically care about this work and leverage the vast amounts of data to assist us in making better decisions. And there is certainly a lot of data. Just think about the number of emails and texts that you send on a daily basis. How many apps do you open on a given day? We are all generating vast amounts of data that we could utilize to better understand the life circumstances of our patients and consumers. With so much data, it's important to understand how you want to utilize it so that it can be organized and managed in the correct way. Likely you've seen a slide like this before that illustrates the types of data analysis that can be completed. We've had retrospective reporting and trending for a long time, and many of us currently utilize predictive modeling for financial and operational metrics, whether for budgeting, staffing, or prioritizing public health interventions and managing risk in a value-based contract. This final component, though, of prescriptive analytics can unlock understanding of personal behaviors and provide realistic and attractive options for patients and consumers regarding their care. At Texas Health, we've taken what we've learned from Annie, Aaron, and countless others who have been so open and vulnerable in sharing their struggles and sharing them with our teams. And together, we are looking for solutions that address both patient experience and patient safety opportunities across the enterprise. And here are a few early examples. At Texas Health, we understand that the care team experience and the patient experience are inextricably linked. And I think Audrey made an amazing case for that with her Resiliency lecture before. We can design an incredible consumer experience, but if we don't set up the care team for success, it doesn't matter. The same is true with patient safety. We can design a beautiful process, but if the training, education, staffing aren't sufficient, it may not have the results that we would like. One of the biggest pain points in any healthcare organization is getting staffing right. And what you see here is improving that care team experience and utilizing machine learning for predictive staffing models so that we have the right staffing at the right times and can deliver on both our quality expectations and our experience expectations. We've also taken consumer feedback and developed services and capabilities outside the hospital as well. Oh, sorry. What you see here, my apologies, is the machine learning that we use for that predictive staffing model. What you see is that the historical data in blue, where we trained the computer and then withheld the last 6 pay periods, and then as we evaluated each model, we knew we had found the right model when the test data and the prediction data, actual data lined up. So this is a really fun use of machine learning that was utilized. We've also taken consumer feedback and developed services and capabilities outside of our hospitals as well. So here you can see studies show that nearly 75% of doctor urgent care and ER visits could be handled via smart device and or video, and we really saw this migration in the past 6 months during the COVID pandemic. So one of those is Dispatch Health. Dispatch Health is an on-demand urgent care on steroids. These vehicles have 75% of the capabilities of an emergency department in the back of their vehicles, and they are more affordable and convenient than an ED visit. As you can see here, what Dispatch does is you can call them or request care online or through their app, and they will come to your home and deliver care for the same price as an urgent care copay. This has been a huge consumer satisfier, but also we've had some great clinical outcomes as well. A great example of this is an elderly patient we had who called their physician because they weren't feeling well early in the morning, and the physician could tell that they were decompensating, and their family member, their daughter was actually at work and unable to come home and drive them to the doctor's appointment. They also didn't want an ambulance to come take them and call 911. So the primary care physician notified dispatch and sent dispatch to her home, and they were able to administer IV fluids and help alleviate some of her symptoms, and then call in a prescription, which her daughter was able to pick up on her way home. And that patient got care probably 4 to 6 hours prior to when they would have received care, having had to wait for their daughter to come home from work and drive them either to the doctor's office or urgent care, and likely would have decompensated and resulted in a hospitalization, which is exactly what they were trying to avoid. Another example of a new service that we've launched is called Hospital to Home. And this is an app that provides free 24-hour access to a local emergency physician or provider, and it's offered to all patients who have been discharged from our emergency departments for 7 days after discharge. And what we know is with that by providing this access, our patients have an avenue for asking questions. We can manage some things, and it reduces ED bounce back, as well as there are also clinical stories here that have resulted in a readmission being prevented. Another example here, we know that medical bills continue to be a burden to many. And so we've been able to create a program through Visit Pay that allows us to learn more about you and provide personalized bill pay options, and it allows you to group all of your family's bills together. So if you're the guarantor on a bill right now, you know that in order to manage, let's say, your spouse's account or your child's account or your parent's account, you have to log into each of those accounts individually and manage things separately. This allows you to put it all together, manage it all in one place, and if you need a payment plan, it's one payment plan, not 3 payment plans, and they're payment plans that are personalized to your situation. And then finally, what if we could help the next Annie? We are looking at other options where we could connect with patients and their families at each stage after disease, coordinate care, and offer tools and tips to help them navigate their new normal. And we are exploring many of these things. Our community impact grants are also addressing unique community challenges of health equity throughout our 16-county service area. So Texas Health has been investing in AI and machine learning, telemedicine, and remote care for the past 2 years. We could not have predicted how these capabilities would help us as the COVID-19 pandemic hit. So I thought I would share our story and illustrate how some of these new capabilities that we have built were essential to our response. So like many of you, our true north was keeping our patients and care teams safe and keeping our employees and physicians supported. And we, like many of you, activated our incident command structure at the local and system levels in late February and had purpose-built teams that were created to address each set of issues to drive rapid cycle design and deployment. An example of this included our clinical ops teams that evaluated evolving PPE guidance, augmenting our bed capacity, where we had dedicated teams creating surge capacity plans with each facility and then consolidating those into a system-wide plan. And we also worked to increase access of care for patients while minimizing risk to our clinicians through virtual visits and telerounding in our hospitals. We also created operational dashboards to allow us to manage the situation in real time, but we also created projected resource needs for 14 days in the future, utilizing models that are updated weekly. So a good example is what you can see is in the top left-hand corner. This is an example of ICU beds. In the upper right of that graph, you'll see a blue line followed by an orange line. The blue line is actual, the orange line was the projected, and those future models were updated weekly. And we were able to see everything from vents to lab tests to inventory of PPE, and we continue to utilize these every day as we manage through what I've heard called the peri-COVID period, which is what we're in today. We have new teams that are reviewing clinical guidance every day, and we're doing demand modeling for this winter to ensure that we have all the resources necessary to be successful. And we have looked at flu patterns for the past several years, aggregated them into a model, and added our COVID experience on top of that to determine testing, staffing, and equipment needs. And we also continue to support remote working, obviously, for those who can perform their duties from home. We have also been engaged in supporting our community in safe opening and what we're calling safe return, really, to work and worship. We created a set of tools to support restaurants, schools, places of worship, and businesses to educate on safe reopening and how to reduce the spread of disease. And beyond tools and templates that businesses can download and print on their own, we are also offering access to clinical expertise and implementation support, because keeping our patients safe extends beyond the walls of our hospital and is essential to us ensuring that we do not get overwhelmed with the healthcare system. While we knew that we had instituted safe and effective processes and procedures for our patients, it was very important to us that they perceive that we were a safe place to receive care. So in conjunction with restarting elective procedures, we began asking patients if they had had a safe experience. And as of, I think this is last week, over 20,000 individuals have answered the question on a scale of 0 to 10, how well did we address concerns for your safety at the hospital during the COVID crisis? And our mean score, I'm happy to report, is 9.38 out of 10, and our net safety score is 83, almost 83. And for those of you who are familiar with how we calculate NPS, the net safety concern score is really calculated in the same way. We are extremely proud of these results thus far, and will continue to monitor for trends and areas for improvement. The other thing I'll say is we also just recently received our ODE mortality scores for our COVID patient cohort, and our current performance is in the 0.7 to 0.8 range across our facilities. So we're very pleased with those results as well. So as you can see, the capabilities that we created within Texas Health played a big part in our COVID response and will be utilized way beyond the pandemic, and really supported our ability to keep our patients safe, as well as provide high quality of care, as we've seen in our patient outcomes and our ODE mortality. In summary, Texas Health is on a journey to really build data-driven and analytic-powered solutions that don't improve patient experience or patient safety. We don't believe in either or binary thinking, because at the end of the day, if we truly innovate, not only can we be the innovators, we, along with our friends and family, will all be the utilizers of the healthcare system that we create, one that has a phenomenal patient experience and exceptional outcomes. So again, thank you for your time today. And with that, I'll close and see if there are any questions.
Thank you very much, Renji. That was awesome. Right now, we have one question in the queue. Do you know if similar models of dispatch health are available in other states, i.e. Nebraska?
Dispatch is available in other states. I don't know the answer specifically for Nebraska, but if you will go to dispatchhealth.com, all one word, and click on locations, it will tell you exactly where they're located. And as I'm doing this in real time, it does not look like Nebraska is an option right now. But if that's something you're interested in pursuing, I am happy to put you in contact with the Dispatch Health team to further a conversation.
Great, thank you. That is a great service. Another question came in, or really comment, great presentation, great ideas for meeting the patient needs beyond the ED. And a thank you from another member. So if you have any questions, you can type them into the question icon. Oh, we got a wow. Good job, Wenji. We'll give it another minute just in case somebody's typing. Appreciate all the great resources focusing on the community's health. Thank you so much, Ms. Mayo. Okay. Oh. Great resource, and hats off to THR. Please remember that the presentations and recordings of this session will be on our webpage. Great presentation from another attendee. Oh, this is a great question. What is machine learning?
Machine learning is where you have a very large data set, and you want to be able to use a computer algorithm that improves automatically through experience. So when we talk about AI a lot, you hear about AI. Machine learning is a subset of AI. And so what you do is machine learning will build a model based on the data that you feed it. So that's known as the training data. And then what occurs is you will continue to feed it data after the initial model. And what it can do is automatically change the algorithm and the model as you feed it more real-time data to predict and help you take a next best action. So machine learning oftentimes is used synonymously with predictive tools or predictive analytic tools. So Amazon is great at this, Starbucks is great at this. So I'll give you a really great example. So as you might know, in retail settings, right, they segment people. And if we were in a room together, I would ask you, how many of you have the Starbucks app? And what Starbucks is able to do is take a really big data set, think about all the people in the world who buy Starbucks coffee on a daily basis, and they're able to feed it into a big data analytics machine, really. And what it can do, right, is not only segment patients, or not patients, segment coffee drinkers in terms of, who different characteristics and traits in how I buy coffee. So are you somebody who goes in every morning, every work day, like clockwork at 6:45 a.m. and order the exact same thing? Or are you a casual weekend drinker? Are you somebody who buys food when you're there or not? Do you, get caffeinated coffee on certain days of the week and decaf on other days of the week? So they can take millions and millions of data points and start clustering people based on their behaviors and how they buy, and they call those consumer segments. And then what they can do is use consumer segments and say, okay, how can I get this segment to buy more stuff from me at Starbucks? So if you get those Starbucks rewards, right, like, hey, bonus star day, if you come in 3 days in a row, you'll get, 10 more stars, right? Or if you come in and buy a bakery item with your drink, you'll get 5 extra stars today. What the machine learning has, what the predictive modeling has taught them is that, okay, and if you have a spouse or a friend or somebody else who also participates in the Starbucks app, you should ask them. They have figured out by segment not just what star bonuses, right, to offer you, what specials to offer you to get you to buy more coffee. They've also figured out what day of the week and time of the day to send you that offer that will maximize the probability that you will buy more stuff from Starbucks. And then based on your behavior, so let's say they send you the offer, you'll either take advantage of it or not, right? That goes into the data. They feed that back to the computer. And as the consumer behavior comes back on how they've responded to that particular offer, the computer does another model and spits out and learns and says, okay, well, that worked pretty well, but based on the behavior, I think this will work even better. And then they spit out a different offer to that same customer segment, and they try it again, and then they learn from it again, and it's all automated through a machine learning process. And they don't do this for just one segment of consumers, right? They micro-segment out, last check, 36, 46 consumer segments, and they're doing this in real time every day, learning about what works, what doesn't work, what you buy, what you don't buy, and then spitting out other new offers, all with the goal of getting all of us to buy more stuff from Starbucks. So that is an example of machine learning at Starbucks. And then I'll let you all take that and think about how you could apply something like that in your own organization.
Thank you for that explanation. One comment came through just saying we might want to reiterate that AI is artificial intelligence in case somebody doesn't know that.
Oh, yes, thank you for that. My apologies.
And somebody else commented this is what is used for COVID models that predict infection rates and mortality rates with a question mark. So they're basically asking you, is this what is used for the COVID models?
Yes, it is. And so, they're clearly not as sophisticated as Starbucks because you need a lot of data for the models to be accurate, right? So when you think about it, in the beginning, we had very little data about COVID, very little understanding about what the true key drivers were of infection. And so the models were widely variable. The more we've learned, the better that modeling has gotten. And so, yes, it is the same type of analytics. Although I would say in the beginning, it was not machine learning or artificial intelligence yet because there was not enough data for the computer algorithms to learn on. So in the beginning, it was still traditional, I would say Excel spreadsheets and manual analytics. But as we get more data, we can turn it over to computer analytics for it to help accelerate our learning. One of the great examples of computer-assisted learning is really in the meta-analysis that was recently published, I think it was in the New England Journal, around all the different types of treatment. They've aggregated all the studies, all the treatment studies for COVID. They've been able to bucket them into different types of treatment and show the efficacy of each type of treatment based on all the studies that have been published and aggregated within one metadatabase and the analytics that have been done on that. And the cool thing is it continues to ingest new studies as they're released, and they continue to update the findings in the model.
Great, thank you. Another question came in. Do you have a paper that we can find more detailed information about your analysis by using real-time model?
We do not have a paper published on that. So the answer would be no. But if you have specific questions, my email is up here, and I'm happy to answer any questions or provide information, or more likely provide you to the expert who could probably best answer your question.
Great, thank you. This is a great question. How can we better address cultural generational barriers to health? For example, people who choose not to address their mental health because of cultural reasons.
Oh, that's a really great question. I don't know. I think if I had the answer to that, I would be a very rich woman. I do think that one of the things that as healthcare providers, we need to do a better job at is giving patients permission to be in that place of vulnerability. And in order for them to do that, we have to ourselves show our individuality and vulnerability and develop that trust. Because mental health and a lot of the cultural barriers come from a place of shame. And until we're able to understand where that shame comes from and be able to give a safe space to speak about and through that shame, we won't be able to crack that nut. I love reading Brene Brown's work on this. I think there's some great nuggets there that we can pull through as providers. But I certainly don't have the answer to that question right now. But when you think about, people who nod to their doctor, yes, of course I'm taking my medications, and they're too ashamed to say, they're only taking half a dose because they can't afford the full doses. That's because they're too ashamed to admit it. And how do we provide a safe space, whether it's with that doctor or a different provider or in a different venue, where they have the ability to share that with us, and then and use some of the tools that Audrey was talking about, right? And not judge, and then be able to support them. And I think if they knew that we had those resources and we need to build them, and those competencies, then we can start really addressing some of those. But no, I don't have the silver bullet to that. That's just where my thoughts and my research are going right now.
Yes, that was a tough question. Thank you. Just another comment. Thank you for making us think of how to apply it. Enjoyed your presentation very much. Let me just do a double check. Great presentation from another. Love your passion. Okay, what can organizations do to help address women who are working and homeschooling and helping elderly parents during this pandemic? I'm sure this only makes access to care more difficult. This may be a question for Audrey even, and I know she's on the line if you want to punt it over.
Well, I would say I think there's two perspectives for us as health systems to look at that. One is looking at as that woman as, a patient and consumer, and ensuring that we have convenient venues like virtual care, like Dispatch Health, and let her know that those are open to her. But we also have a responsibility to our employees. 80+% of our work force at Texas Health is women, and we have been very intentional during this time to make resources available on care.com. We've looked at child care venues specifically for our employees. We have a fund where we will cover a lot of the expenses on care.com should our employees need it. We've deployed psychological first aid in all of our care venues. And we, put out tips on a regular basis. And we've armed our leaders with the ability to have conversations and what should those check-ins look like, because it's a new skill set and a new situation, in order to really understand what's going on with their employees and to build the flexibility to support that. But I would love to hear Audrey's take on this as well. I know she's got a great perspective.
Audrey, are you still on? Oh, she might have dropped off. We can get that question answered and sent out from Audrey's perspective, but that was a great answer and a difficult one. That is all the questions we have in the queue. So I want to thank both Audrey and Winji. The presentations were awesome. I hope everybody got some takeaways from these that you can use in your own facilities. As I said, a reminder that the evaluation will open up after our last session on October 1st, so it will open October 2nd. It is linked on our webpage. Please go see our posters, do the short quiz. It's 10 questions, and you get in a drawing for the autograph book from Megan. And please remember that the link that you use to get into today's session is good for all the rest of the sessions. So save that link, and that will allow you to get into the next two sessions that we have planned. I want to thank everybody. We really appreciate it. Session 2 of the Patient Safety Summit is now complete. Thank you, everybody.